everybody. Can everyone hear okay? Clap once if you can hear. That worked in a presentation earlier, so I'm happy to see that. So welcome to PeerView Live's presentation, Keeping Brain Health Top of Mind. We're talking about preserving cognition and improving early detection and diagnosis of Alzheimer's disease. So tonight's panelists, I'm Amy Klingler, I'm a PA. Dr. Scott Kaiser is with us, and Madeline Paczynski. So we'd like to thank PeerView and the Gerontological Society of America for providing this session, and to Lily for providing the educational grant for this workshop. If you haven't already, please complete the pre-event survey and keep your phones available and silent so you'll have additional polling questions throughout the presentation. So if you have questions that you want to submit through the polling along the way, we'll answer them at the end during the Q&A session. In-room learners, you'll use your personal device to scan the QR code on the following slides to respond to polls and to ask questions. Virtual learners, please respond to the polls on your screen and enter the questions in the chat window, and those will come to us. So for in-person learners, this is your QR code, so scan the QR code. Each action you do increases your chances of winning. That includes the pre-event survey, the polling questions, and submitting questions to the three of us. So if you get this green lucky screen, see one of the PeerView team members to claim your prize. So thanks to PeerView for the gift cards. So you can see us virtually at peerview.com, NOLA26. The QR code will give you access to slides, practice aids, and additional resources that you can access and download after the session. So if you have any questions or need assistance, you can send an email to PeerView or join the conversation on X. So some more QR codes. We have so many today. So these are important QR codes as well. So peerview.com QR code gives you the case simulation and a cognitive health activity. And we also have resources on brain health and Alzheimer's disease at the PACE Alzheimer's QR code. So we wanted to draw your attention to some educational resources that the AAPA has for patients and for providers. So we have the Alzheimer's disease and brain health toolkit. So that's for patients, providers, care partners. It has downloadable resources for early diagnosis, screening, and treatment resources for Alzheimer's disease. And we also have the Neurology and Brain Health Toolkit to enhance your knowledge of neurology and brain health, up-to-date CME resources, research articles, and more. So access to those websites is in the Additional Resources tab and in the downloadable slides. So again, welcome. I'm Amy, and I'll be the moderator for tonight's discussion. So our first question, which of the following is the greatest barrier or challenge you experience in your practice when addressing cognitive health? So you'll scan the QR code and answer that. And again, please, you'll choose one answer. We know they're all barriers, but we'd like to see what's the most impactful for you. Limited time during routine visits, uncertainty about which screening tools to use and how to interpret the results, just kind of some discomfort in talking about cognitive decline with patients and care partners, lack of access, kind of feels futile to have the discussion, but then there's also an all of the above. Great. So what we're seeing, over half of people note that limited time during routine visits to discuss and assess modifiable risk factors for dementia and cognitive concerns is the greatest. And I think that kind of mimics what we're all seeing in practice. We have less time to do more, but there's still a fair number of people who have some uncertainty about the tools, some discomfort, and lack of access to specialists. So we hope to help address some of these issues through our talk today and give you some tools to try to help your practice and help expedite your evaluations. So we just kind of want to introduce a few things about Alzheimer's disease and the importance of advanced practice clinicians in addressing Alzheimer's disease. So just a reminder that dementia is one of the biggest global health crises of the 21st century. Alzheimer's accounts for 60 to 80% of dementia cases. So by 2060, currently we have about 7 million Americans living with Alzheimer's disease, and that number is expected to double by 2060. So this is a very an opportunity to intervene and make some improvements in your patient care. So our health system, despite this concern about more Americans living with Alzheimer's disease, we have a shortage of dementia care specialists. Our infrastructure is underprepared for managing this number of patients, and we continue to have a growing aging population. So what we're hoping to address today is that feeling that a lot of us have that we're under-equipped and to diagnose and manage the complexities of dementia. So we know that PAs and nurse practitioners have become primary care clinicians in these dementia care models, and that we are managing our patients across the entire spectrum, from initial evaluations and symptom management to research and advanced care planning. So this gives us an opportunity to intervene and really make a difference in our patients' lives and the lives of their care partners, because as you'll see, that's also quite important. So today, during this workshop, we're going to engage patients in conversations about cognitive health and modifiable risk factors for dementia. We're going to help identify potential concerns and help facilitate early intervention. We'll detect and classify early cognitive changes through routine cognitive assessments. And we'll talk about blood-based biomarker testing to detect early Alzheimer's pathology and determine next steps in diagnosis and management. So we're talking about the CARE framework, and that will pop up throughout this talk today. So CAER is a collection of practical resources and clinical tools to help manage and make positive improvements for our patients. So we're going to kickstart the conversation. We're going to assess for cognitive impairment, evaluate for dementia, and refer for resources in the community when needed. So we will follow a case throughout the course. You'll gain more information about Hector, our patient, as we go along and proceed. So Hector is a 64-year-old male. He's a small business owner with a 4-year degree, so 16 years of education. He's widowed and lives alone, and he comes to you for a follow-up after starting treatment for high blood pressure. His blood pressure currently is 138/80, which was down from an initial level of 150/80. His total cholesterol was 225. He does have both obstructive sleep apnea and insomnia. His BMI is 34. His medications include a combination calcium channel blocker, ACE inhibitor for hypertension. He takes an over-the-counter sleep aid 4 or 5 nights a week to help with sleep. He does note that his mother had dementia in her 80s and his father died from an MI in his 60s. So we're going to come back to this, but kind of keep Hector in mind as we move through the presentation. And now I'd like to introduce Dr. Kaiser from Determined Health in Los Angeles, California.
Thank you so much, and great to be here. I love this room. We should have borrowed the basketballs from them next door. We get a little brain-healthy activity in here. So when's the time to approach dementia prevention? Always. It's always the time. That's the answer. It's always the time to approach dementia prevention, because we have opportunities for primary, secondary, and tertiary prevention. As you heard, we've got this aging population, right? We've got 10,000 people turning 65 every day. It's projected that by 2050, 150 million people will be living in the world with dementia. But there are opportunities across the lifespan to help people reduce risk. And this is stuff that I'm a family physician, geriatrician, practiced across a variety of settings. I'm sure you practice in a variety of settings. Wherever we are, we have opportunities to help patients and families reduce risk. right? So we can get ahead of this when we're dealing with people across the life course. When people start to have early symptoms, we need to identify those people suffering from mild cognitive impairment and be able to address modifiable risk factors to reduce their risk. And then as people's cognition further declines, there's opportunities to slow that decline. It's never too early and never too late. And when it comes to brain healthy lifestyle and helping people address their underlying comorbid conditions, the things that we know help slow things down, we know it works. This isn't just, oh, that seems like it would be a good idea. This is clearly evidence-based, right? So we had the finger trial done in Scandinavia where they looked at people who were at risk for dementia and they said, hey, what if we get them exercising? What if we talk to them about managing their comorbid conditions? And then people said, okay, well, that worked in Scandinavia, but will it work everywhere else? And sure enough, we have the data. It's worked here in the United States. And what's really striking about the Pointer study results is that there were two intervention arms, one that was structured and one that was self-guided. And they both improved relative to a true control. So amazing if we can get people the coaching they need to be able to make sustainable change with regard to exercise, cognitive and social engagement, healthy, brain healthy eating, and monitoring their own conditions. But even just talking to patients and families about it and giving them some general guidance to go about it on their own is going to be impactful. Certainly more impactful than what's all too often the status quo of doing nothing. When we talk about modifiable risk factors, so this is a list of modifiable risk factors from the Lancet Commission, a group of experts that gets together and reviews the literature, looks at risk factors for dementia. And this is a list of, I think, 14 factors, which is growing, by the way. The first time they met it was 12, and then they added 2 new ones, and I'm sure they will continue to add to this list. But what I want you to see about this list is this is a collection of factors that impact all of us across the lifespan. And it's thought that if we successfully addressed all of these factors, something on the order of 45% of dementia cases could be prevented altogether. So remember that 150 million people number I shared a few moments ago? Imagine if we could cut that by 45%. And now look at this list and think about how many of these things are right in my grasp. How many of these things are already right on my plate, things that I should be dealing with: high cholesterol, helping people address their blood pressure, helping people get active, again, avoid excessive alcohol, eat a healthy diet. And then think about things on this list that maybe are slipping right by me, but are also still in my grasp. Like, am I making sure that I'm thinking about loneliness and social isolation, that I'm thinking about the relationships and the connectivity and the networks of our patients and how they're feeling with regard to that critical factor, particularly our older patients, and are we helping screen for that and address it? Are we looking for things like untreated hearing loss or visual impairment so that we can address these factors? So again, when we think about these potentially modifiable risk factors, this is stuff that fits very nicely across kind of a global holistic practice. And the key, I think, is to just start having a bit more of a systematic approach to addressing these. And what's cool is that you can actually use these factors to help give people some risk score and risk stratify populations. And there's something called the CADE score that looks again at a lot of these cardiometabolic factors and age and education level, so that we can not just sort of guess, but actually start to risk stratify patients. And then this is something I've really been enjoying learning about. I have to admit, I don't use this in my practice yet, but I'm looking forward to starting as I become more familiar with it. The McCants Brain Care Score from Mass General. I love this because we're looking at those cardiometabolic factors, age, et cetera, but then we're adding all of these other broader factors that I think are so critical to address when you're thinking about these problems holistically. I love to see that social relationships, sense of purpose, meaning in life are on there. As a geriatrician, that's like the superpower stuff. And then, of course, nutrition, alcohol, smoking, exercise, sleep, critical stuff in the lifestyle domain. So this is pretty cool, and I think something that could be really useful to work with your patients in collecting this so that they can think about it. And in fact, it looks like they've developed this great platform where you can actually, check your own score and then actually get some guided recommendations based upon that. So we've been talking about kind of the things we should be looking for and the things we should be doing, but how we do it is probably as important as what we're doing, right? How we go about it. We really need to think about this is a sensitive topic, right? So the good news is we're going to normalize brain health, and we're going to talk about it with all of our patients and all of our families. We're going to build it into every aspect of our practice, and as we'll talk about, we're going to talk about what's good for your heart is good for your brain, and we're going to again emphasize the normalcy of addressing this and the importance of this for everyone. But that said, when we're talking about memory loss, cognitive impairment, when we're talking about looking for things like dementia, these are very sensitive, loaded, triggering topics. So we cannot just come in like a bull in a china shop. We have to be thoughtful about the way we communicate. And that's really about not just what we say, but our nonverbal communication, the way we're setting up the environment in which we're doing this, certainly then what we say, and then having some cultural sensitivity, knowing that there's really different cultural factors that affect the way people think and feel about these things. We have to keep that in mind. So when we're talking about brain health with all of our patients, here are some great things to keep in mind. As I said a moment ago, the brain ages just like other parts of the body, and we've got to take steps to take care of it, and that there are steps we can take to take care of it, right? Many people still hang on to this old fatalistic thinking that, there's nothing I can do, my mom had it, I've got a family history, it's going to happen to me, and by the way, every time I go into a room, I forgot what I went in there for anyway, and I keep losing my keys, so forget about it, why bother, right? We can't think that way. We have to understand that, first of all, those modifiable risk factors, the lifestyle factors, they far outweigh. It's been clearly documented that those types of factors you can mitigate any genetic family history risk you might have in the vast majority of cases. So people need to understand that there are all of these things we can do at every step along the way, so that way we can come in with a very positive, proactive set of messaging with our patients. And I think many patients will find that to be very refreshing, to step away from the doom and gloom and to have somebody who wants to be their partner on a positive journey together, really looking forward. I always get a funny look from patients when they're 80 years old and I'm talking about planning for the best next 20 years, right? But I'm always thinking of sort of the 100-year life and how we're going to get the most life into those years. And again, so what's good for your heart's good for your brain. Understanding that cognitive aging is very heterogeneous, different for different people, so we're not going to jump to conclusions. We're actually going to, as we hear tonight, actually investigate. We will assess, we will evaluate. We're not going to dismiss concerns. We're actually going to get objective information. And that cognitive aging in and of itself is not a disease, right? The brain changes with age. The fact of the matter is, typically, yes, processing speed goes down. That's really the big one and has the big impact on a lot of common age-related complaints. But the brain actually gets better with age in certain ways as well. And we can always improve our brain at any age, right? So the thing is to separate the fact that there are these normal changes from the fact that there are conditions that are not normal that we need to be on the lookout for. And that's why we're going to work together, and we have approaches to be able to identify those things, catch them early so that we can do something about it. So coming back to this idea of what's good for your heart is good for the brain, right? There's this whole wheel of things here. Again, if any of these things is a surprise to anybody here, we have to have a little talk, right? This is not breaking news, right? They're not knocking down the door from CNN to talk to us about, oh, we didn't know that smoking was bad for our brains, right? But the trick, as we all know, is forming that alliance with patients so that they can actually do something about it, set actionable, attainable goals, and then maintain positive change over time. And again, just sort of have to say something about this risk factor. It's very near and dear to my heart. I spend a lot of time thinking about the impact of loneliness and social isolation, working on solutions for people. And I'll say, this is highly under-recognized. It's something that we can just talk to our patients about. It's also something where we can integrate useful tools into our practice to actually have some formalized screening, something like the UCLA-3. And it's something that we can do something about, right? There are social prescriptions that are extremely effective in addressing these things, whether it's something like a friendly call program, something where just a trained layperson calls and spends time with somebody on the phone. We know that's been evidence-based, demonstrated, randomized controlled clinical trials showing that those can reduce loneliness, isolation, depression, anxiety, and have other positive impacts. So again, we're going to work with patients to develop a brain health plan. It should be as routine as managing blood pressure or blood sugar. We're going to tailor that plan to people's unique needs. And we know that we are going to make personalized and attainable goals so that we can give our patients the best opportunity for success and then guide patients towards evidence-based strategies. Because there's no shortage of commercials and things popping up on their web browser that are telling them all sorts of stuff that there's no evidence for, that looks so easy. Just click there and all their problems are solved. We need to counterbalance that with the mountains of evidence of things that we know work, many of them being obvious, but we need help getting there. So here we've got a video to hear from a patient specifically about this important topic. So I think that'll come up.
Given the importance of brain health, I think it's vitally important that general practitioners are talking to their patients as early in life as they can. We know this disease develops early, and so the earlier pointers we can get, the better. I would like to think that all primary health practitioners had a close enough relationship with their patients that they would indeed initiate any conversations regarding mental capacity, cognitive issues. So absolutely, I think the earlier we can diagnose these problems, the more likely we are to be able to provide beneficial treatment. I understand that many of us are hesitant to talk about brain health. It's worry, but I really think that your primary care practitioner should be the first person, the first line of defense, should be the first person you talk to. If you have any concerns about your brain health, about cognitive issues, I always advise people to talk to their primary care practitioner first.
I love that. I love that video. Okay, so, and we need more people like him who are going to be proactive and coming in and coming to us. And then, but we can't wait for them. We need to bring it up first, too, at the same time. I love that. Okay, so coming back to our case. So you have all the info at your table. You're going to go work on the cases now. People are going to come around and help you with the cases here and discuss it. But so remember Hector, and think about all the things we've been talking about, right? He's 64, he's got these health risk factors, maybe he's on some medications that he should and shouldn't be on, he's got a family history, right? So take a look at these visit notes. We know that he's gained some weight since his last visit. He's feeling less energetic, and he was recently diagnosed with sleep apnea. Okay, so I'll leave it to you all to discuss. All right, excellent. Okay, so you had the pretest question. Now's your opportunity to reconsider your choice. So now you're following up with Hector, 64-year-old man with stage 1 hypertension, sleep apnea, insomnia, obesity. Given his age and dementia risk factors, what is the most appropriate way to address his cognitive health? If you have to pick the best answer here, go ahead. Use your, oh, I love everybody scanning those QR codes. You guys are on it. Okay. All right. Yeah. So 75%. Briefly. Wait. Which one is the pre? Uh-oh. Oh, guys, we're going in the wrong direction here. We're going in the wrong direction here. Yes, we want to incorporate brain health as part of the overall health discussion in today's visit. We have to. But I guess, so let's talk about this real quick, just to help us out, because I hate that we went in the wrong direction. So we don't only want to focus on his medical conditions, right, and address brain health at the next annual wellness visit. We're not going to wait. We're going to focus on his medical conditions and address his brain health. And in reality, we're going to schedule a follow-up soon, because we're not going to be able to cover all this in one visit, but it's really important. And as we move through that care toolkit, we're going to need to move quickly to the next phase, because we've got some work to do, right? So we are going to do it all. But if we need to schedule a follow-up visit, that's fine. We're not going to just wait. And certainly we don't need to refer him to a specialist right away. There's so much we can do now. And even if we are thinking that, this is somebody, later tonight we're going to talk about the, things like biomarkers and treatments, and we might think, okay, we want to get into treatment early, so we need to get the specialty referral. Great, maybe. But nonetheless, there's so much we want to do so that we can be a great partner to the specialist and really be the quarterback who's best supporting the patient, and so much groundwork we still have to do. And not sure, totally fair. At least the not sures went down. At least we got more certainty. We were certainly, okay. Okay, so just some quick summation from these discussions, right? So we've got modifiable risk factors, hypertension, obesity, sleep apnea, insomnia. He's using an over-the-counter sleep aid, right? That's got diphenhydramine in it. That's like public enemy number one for us Beers criteria, American geriatric type folks over here. Okay, whoa, very bad. Sedentary lifestyle, big problem, right? So we need to figure out more about his diet, more about the social connectedness. We were worried, right? He's recently widowed. He is living alone. He's sounding pretty isolated. We need to get more information, and maybe even some grieving that's moved into depression. He's got a family history, so that's non-modifiable. So we've got some work to do. And I saw people calculating the CADE score. Awesome. Yes, go for it. So we got a CADE score of 9, and that's excellent. And then maybe we'll even get more of those lifestyle and social factors and do the other score as well. So very good stuff. So our plan is we're gonna improve our antihypertensive management. We're gonna work on an attainable, sustainable physical activity plan. We're gonna address the sleep apnea and optimize sleep. We're gonna work on reducing his weight safely, and we're going to address any depression and social isolation. And with that, I'll hand it back to you, Amy.
Great, thanks.
Right.
So now we're going to talk about, is it more than aging? We're going to build our toolkit. Again, the more tools we have, the more ways we can help our patients. So we're going to help detect cognitive impairments. We can move forward with treatment and modifying some of those risk factors. So we're going to hear from George King again. He's our patient with dementia who's been very vocal about his disease and some of the factors there.
I first had concerns about my memory, maybe 20 years ago. It seems bizarre, but this diagnosis really snuck up on me. I wasn't expecting it, but at the same time, a lot of the symptoms I was experiencing seemed to have been there for a long time. I was playing a word game one time, and the word game said, you already thought of that word. And I immediately thought, oh my gosh, my short-term memory, this was only a couple of seconds before, it had already just taken it sort of out of my mind. And based on that, I decided to seek further help. You know, I really was the first person to notice this shift, if you will, or these concerns. And when I went public and said, I'm living with Alzheimer's disease, some of my close friends literally said, you were always like that. And I just cracked me up. And I realized that some aspects of my personality or something, you know, just lent themselves to some of these symptoms. So, no, I was really the first person to notice, and nobody kind of tapped me on the shoulder and in fact, when I mentioned this to friends that I was dealing with this diagnosis, they said, well, that happens to me too. I mean, I do that all the time. And so I have to reassure a lot of people that if you're concerned, you should go see your general practitioner. But really, there are some memory issues that are just a normal part of aging.
And so George is pretty interesting because one, he's very proactive. He, didn't have a lot of people in his life telling him that he needed to get checked. He really noticed it himself and started moving forward, which is pretty, in my practice, it's a little bit unique, but really exciting to see that self-advocacy. And then it also speaks to the idea of, the underdiagnosis of mild cognitive impairment. So how often we're missing and dismissing concerns about mild cognitive impairment in our practice. Sometimes because we are rushed, like we were talking about. It's like, oh my goodness, I have to now have a talk about brain health after I've just dealt with your 4 other chronic diseases. So we want to talk again about who and when we should be evaluating patients with cognitive impairment. So again, anyone who self-reports, anyone whose family members, care partners, in my community, it's neighbors who a lot of times will mention something to me. I live in a small town, so neighborhood talk is very important to how we transfer information. But when patients have concerns, if they're noticing behavioral changes, if they're noticing cognitive changes, then we don't want to dismiss those complaints. We really want to set time aside, and sometimes that needs a special visit to do that. So one of the things that I really like about this slide is that it talks about checking our patients for hearing and vision changes before we're beginning our cognitive assessment. So I've had patients who are very anxious about their cognitive assessment, who do very poorly when they're very nervous about it, as well as people who do really poorly on their assessments when they can't hear my questions and when they can't see the clock that they need to write the numbers on. So we want to make sure that we've mitigated some of those factors that will interfere with our accurate assessment of their cognitive health. And then we're going to talk about incorporating family and care partner concerns, because that's sometimes we're not, as patients, noticing changes as quickly as some family members are, or again, neighbors in my community. So we do have some cognitive assessment tools, and we want you to kind of build your tools and find out what works for you and how you can incorporate it most efficiently and effectively in your practice. So a lot of times I do these in sequence. I'll do them in different ways, but and sort of based on my level of concern for the patient. So brief cognitive screening, the mini-cog, takes 2 minutes and is actually quite effective when implemented regularly. And I also use mini-cog, in patients over time. So we're doing mini-cog at least every year as part of routine screening if we're not doing a different screening or a more comprehensive screening, so we can monitor for changes. So the other tests that can aid in diagnosis, the MoCA, the SLUMS, the RUDIS, and the 88 we're using kind of as a functional screen and as part of our diagnosis. So the additional assessment tools we can use are looking at activities of daily living and mental health. So geriatric depression scores, PHQ-9, all factoring into some of these lifestyle things that we've talked about and some of these ways that we can intervene. So this is just a kind of a refresher on the mini-cog for those of you who are not familiar with it. There's 6 different word versions. So patients, you'll tell your patient, I'm going to say 3 words, and I'd like you to repeat them back to me and try to remember them. So you choose a word list, and then you allow the patient to repeat them. You can give them multiple attempts on that. Then you're going to distract them from what they're trying to remember and have them do the clock draw. So, put all the numbers where they go on the clock, and then have them draw the hands on the clock so the set time reads 10 past 11. My patients will sometimes come in the next year and say, banana sunrise chair, because they were and so then I use a different version on them. But because they were so in tune, and they might have missed one last year and really remembered it and worked on it over the course of the year. It's pretty fun. So then moving on to the AD. Oh, I wanted to go back because the scoring on this is pretty interesting. So you get 3 points, 1 for each word. And for the clock drawing, you get 2 points. And your total score is from 0 to 5. And then this has greater than or equal to 3 is considered normal and a passing score, and less than 3 is considered failing, although I don't like to tell my patients they failed their brain health test. I do like to say it gives us an opportunity to do some more screening. I think 3 historically was kind of an in-between where it was above 3 is normal and below 3 is not normal, but I have a bunch of people that end up with 3, and so I actually consider 3, I'll usually do additional screening on patients who score 3 on their mini-cog because it's so quick and because it's pretty generic. So the 88, this is a great tool to get care partner input because patients may say, no, I haven't had any changes in these, but their care partners will say, sure, you're not going to yoga anymore. You asked me 6 times about, when we're going to the neighbors for dinner. Trouble learning. I have trouble learning new tools, so this might actually work for me, but, learning how to use their new phone, problems making decisions. So this is really important. This is a real functional tool, and this gets at not only is the patient having memory impairment, but are they having trouble with function? So when should you schedule a dedicated visit? We talked about the time issue that so many of us have. So we do the mini-cog, say, or the patient mentions a concern. If a patient mentions a concern, I'm not choosing the mini-cog as their screening. When a patient mentions a concern, I want them to have a little bit more in-depth screening. So any of those times, we're going to go for further assessment. So we have these different tools to help with diagnosis. We have the MoCA, the mini mental status, the SLUMS, and the RUDIS. In my practice, I'm using MoCA most often, and I'm also using SLUMS quite a bit as well. Sometimes I'll rank them. So SLUMS is actually quite validated, but there's more questions on MoCA. So based on my levels of concern, sometimes I'll schedule multiple visits and do multiple screenings, or I'll do them in sort of sequence and check MoCA, and 6 months later check a MoCA again. So there's different costs and different access. So whatever you're using in your practice, be really familiar with it, get comfortable with it, and that can expedite the version of it. There's an opportunity, and I think we'll talk about it, to have staff help with the screenings or do it yourself. I'm a kind of do-it-yourself kind of gal, so I end up administering them a lot, but if you're stressed for time in your visits, it's an opportunity to have staff help out. So the MoCA is the best validative tool for identifying MCI. It is available in multiple languages. It's a little bit more sensitive than the MMSE, does not have copyright restrictions, and can be corrected for education levels. So when you're training staff to conduct the cognitive assessments, that can improve your efficiency. We're all looking for that. So it can be done by any number of people in the office. They can help integrate the scores, because really one of the most important things for me is monitoring MoCA over time. So I like to know those numbers and see how they change over time. So we're going to monitor that. So there are digital cognitive assessments that are available. So there's 5 of them listed here. They do take a little bit of time, but it's worth becoming familiar and finding out if your practice or if there's something that can integrate into your electronic medical record. So when we're looking at cognitive changes, we're looking at sort of the spectrum from unimpaired cognitive function to severe dementia. So when people are unimpaired, they have normal cognitive function and no functional impairments. Subjective is our self-reporting patients. That's when patients are noticing changes, but they don't have any objective evidence of cognitive impairment or functional changes. So when we get into MCI, they're having early functional impact, but they're still able to do basic and instrumental ADLs. As we progress into dementia, what we're seeing is an increase, a greater loss of independence in their ADLs and their progressive cognitive changes. So mild, moderate, and severe. So when you get into moderate, patients are needing more assistance with basic ADLs and then become dependent. It's always tricky for me, what's a basic ADL, what's an instrumental ADL, and so I like the idea that a cat can do basic ADLs. So they can dress, they can bathe, they can toilet, they can walk and eat. But instrumental ADLs are things that you need to do like when your child goes to college. They need to know how to do these things. So a cat can do basic and a college student or a functioning adult needs to be able to do those instrumental ADLs. So this is how we can assess functional impairment in the ADLs using the 88 or some of the functional assessments. We can also get that information from patients and from their care partners. So how much assistance do they need with those things? So the degree of impairment in these ADLs is the key to distinguishing between mild cognitive impairment and dementia, and just the age-related forgetfulness. So why did I come up the stairs? Our brains are not tuned to remember every single thing, and so there is some normal age-related forgetfulness. But mild cognitive impairment, we might see patients asking repetitive questioning, unable to complete complex tasks, which are often multi-step tasks, but they're still independent with their activities of daily living. When we move into dementia, that's when patients are losing that ability to perform ADLs. So when we're talking about mild cognitive impairment, this is a really important point to intervene. So intervening at mild cognitive impairment, because mild cognitive impairment is a diagnosis and it can give us some tools and some opportunities to intervene. This was pretty interesting, and when we were talking through these slides, this really got my attention, and I really looked back in the resources, because I used to kind of refer patients, and I would say, this is mild cognitive impairment. There's a small portion of people who progress to dementia, but we're going to try to intervene. And without intervention, it's actually quite a large number of patients with mild cognitive impairment will progress to dementia. So we want to, if we're giving our patients this diagnosis, we really want to give them the tools, make the lifestyle changes, make the behavioral changes, control their modifiable risk factors. So we want to also note that the MoCA score between 18 and 25 with intact activities of daily living typically indicates mild cognitive impairment. So this is a real opportunity, and it's kind of changed the way I think about MCI, not just, oh, it's okay, you have MCI, you're not going to progress that quickly. It's really, you have mild cognitive impairment. This is when we need to intervene to prevent progression. So patients with cognitive impairment do need a diagnostic workup. They need cognitive assessment, functional assessment. We want to know what their care partners are noticing about changes in their functioning. We want to know their family history, their medical history. We want to know their lifestyle data. This is all stuff we can gather and incorporate into the McCants or into the CADE scores to help us. We want to look at their medications, including over-the-counter medications and supplements. And we put this in bold because this is really important stuff. We were talking about Beers criteria. These medications are linked to memory issues. And if we can de-prescribe some of these medications safely, we can really improve our patients' brain health. I've seen cognitive impairment increase dramatically with taking gabapentin out from a patient's medication list, with reducing their benzo use, and certainly with getting them off of sleep aids for nighttime. So just remembering the impact that has. Behavioral assessments, neurologic exams. We want to look at lab tests. Are they B12 deficient, vitamin D deficient? Do they have a thyroid issue? And when we get those lab tests and we find a place that we can intervene, usually what I'll do is, supplement the B12 for 3 to 6 months and then reassess and repeat the MOCA. So when you find something along the way, you have an opportunity to intervene and reassess. So you can get brain imaging. MRI is our preferred test, but a lot of our geriatricians and neurologists will accept CAT scans because in some of our communities, MRIs are really hard to get, and there's a lot of delays in care if we're just waiting for that MRI. Then we're going to talk about biomarker testing as well. So pitfalls in interpreting, we talked about the emotional distress. If people are tired, if they're anxious, if they're sick, that may contribute to false positives. If they cannot hear well, if they can't see well, if they can't hold a pen well to write the numbers, if they have chronic diseases like sleep apnea. So other false negatives, high education, patients can cover up. Sometimes you have to sit and talk to a highly educated patient for a little while to figure out that they're actually experiencing some cognitive changes because they can kind of fake it for a little while. And then when patients are familiar, that's why I have to change the word list every year because patients try to remember that. We want to make sure we're testing them on a good day. So low literacy, limited education, developmental and intellectual disabilities, and culture and language barriers can also make us use a little extra caution. So we want to interpret the whole picture. We talk about holistic care. We want to look at our whole patient. So when we're acting on our workup findings, if the workup looks okay, we're going to still talk about those lifestyle factors to maintain brain health. And then we're going to always be repeating these studies. So if we find contributing factors, we're going to help patients take steps to reduce modifiable factors. We're going to help them reduce their alcohol. We're going to make sure they're wearing their hearing aids, that we correct lab levels. We're going to make sure we're treating sleep apnea and depression. We may de-prescribe whenever possible. And then if it looks like MCI or dementia, we're going to talk about that. We're going to talk about the stress and the emotional weight of that, but we're going to make a plan. We're going to make a plan for a follow-up visit. We're going to make a plan for multiple follow-up visits. And we're going to encourage our care partners to come with our patients. So we don't want to diagnose the patient and send them home with a mild cognitive impairment diagnosis because you'll get lots of questions in your in-basket from the patient requesting that be removed from their diagnosis list if you don't really explain what's going on. So now we're going to talk about Hector again. What we've noticed and what's changed a little bit over time is in our visit notes. So Hector reports that maybe his memory isn't quite what it used to be. He's been forgetting to take his medicine, but he figures that's part of getting older. And his primary care provider administered a mini-cog and his score was 3. So we're going to give you a little bit of time to think about Hector again.
Okay.
on your devices. So Hector was nearing the end of his appointment with his PCP, and he mentioned some memory changes. So he might be forgetting to take his meds, his mini-cog is 3. And now what do we do to assess Hector and distinguish normal signs of aging from MCI? So scan the QR code and give an answer. All right, so excellent. So I recommend against immediately administering the MOCA or an urgent MRI. We've been through the office visit. We're doing this. What we really want to do is schedule a follow-up appointment. We want to have some dedicated time to administer the MOCA and a cognitive evaluation. That gives us time for some family member input about his daily functioning. And then we can see from there. I wouldn't quite order blood-based biomarker testing yet because we have a little bit more work to do. I wouldn't, as we talked about, the mini-cog score of 3, which is quote normal, still not my. We want him to do some more discussion.
You did a much better job than me. Look how much better they got.
So in our small groups, Hector would benefit from additional testing because he reported cognitive symptoms. His mini-cog score of 3 is kind of in the normal range, but in my opinion, it's a bit ambiguous. The MOCA has good sensitivity and specificity. We can administer it with a pen and pencil, paper and pencil, or digitally. We want him to have a follow-up knee assessment because there's not enough time. We all know that the MOCA takes time, and just the discussion itself is going to take some time. So we want him to get an optimal score. We want him as fresh as possible. We don't want this at the end of a visit or the end of a busy day. We'd love for him to bring a family member with him, and we'll try to get the 88, some functional assessments, and then if we're concerned still about MCI and dementia, then we'll complete that full diagnostic workup. And we'll turn it over to Madeline.
Thank you. And so we're going to pivot and talk about optimizing early Alzheimer's diagnosis, enhancing team-based clinical workflows with blood-based biomarkers for effective triage and referral. So we're going to start out with a question, and so use your device. Which of the following is the greatest barrier to implementing blood-based biomarker testing for AD in your practice or institution? Is it the lack of clear clinical workflow or pathway? Is it the uncertainty about what test or vendor to use? Is it the limited access to specialists for follow-up or consult? Is it insufficient training of ordering clinicians? Or is it the absence of institutional or leadership buy-in, or all of the above? Many problems, yes. All right, so keep that in mind. Okay, so the rationale for blood-based biomarker testing in primary care. So as most of you know, primary care clinics are at the front line of diagnosing everything, and now we're really relying on them for identifying AD. So the FDA has approved amyloid targeting therapies, and this has greatly increased the need for biomarker testing because these therapies require confirmation of amyloid pathology before starting treatment. So blood-based biomarker testing in primary care is needed to enable adequate testing in a timely manner while reducing specialty care wait times. A recent study found that adding blood-based biomarkers to a traditional cognitive screening measure in primary care reduced specialty care wait times from 50 months to 12 months. Primary care clinicians should refer complex patients and those likely to be eligible for amyloid targeting therapies to specialty care before they progress beyond eligibility for treatment. So the current indications for clinical AD biomarker testing Clinical AD biomarker testing is indicated for patients who have undergone a comprehensive diagnostic workup for cognitive impairment, like what Amy just went through, and who have objective evidence of cognitive impairment. And those who AD is likely the cause of cognitive impairments. Not everything is Alzheimer's. And biomarker testing is expected to affect diagnosis and management by either improving the accuracy of an MCI or dementia diagnosis, or determining whether patients may be candidates for AD-specific treatments, such as amyloid targeting therapies. Big emphasis on biomarker testing is not currently recommended for individuals who are not cognitively impaired. So a potential pathway for earlier AD diagnosis and treatment, and so we really rely on our primary care providers to detect cognitive symptoms. You may hear from family or neighbors, in Amy's case, or the patient themselves, and you should, if there's any concern, you should do a formal screen for cognitive symptoms. And if that is positive, you should move on to the diagnostic workup for cognitive impairment, and this is something we should all be very familiar with. You should do some functional and behavioral assessments, get a thorough medical and family history and lifestyle data, have medication review, a neurologic exam, routine labs, and brain imaging, such as an MRI. Then, when you have all of that completed, you should discuss the results of workup and differential diagnosis with the patient and a care partner. And you should discuss AD biomarker testing if appropriate, and make sure that the patient and the care partner are on board with the potential of testing. If they are, and it's clinically indicated, you should order the test and then be prepared to discuss the results and what that means for the patient. And if the patient is within the milder stages of the disease and has evidence of AD, they should then refer to a memory specialist. If you have an inkling that this patient would be a good candidate for an amyloid targeting therapy, you should make that clear on the referral as well. So these are the clinically available blood tests in the United States, and so there's many blood tests hitting the market at this time. In 2025, 2 blood tests were FDA cleared. That was the Roche Alexis p-tau 181 test that was approved for use in primary care, and then also the p-tau 217 amyloid beta 42 test by Fuji Rabo. Not all blood tests are created equal, and so there's large variability in the performance of blood-based biomarkers. And we know from many studies that p-tau 217 is the golden child. Specifically, the percent p-tau 217 combination with amyloid beta 4240 by C2N Diagnostics really outperforms other blood-based biomarkers on AD-related measures such as amyloid PET, early tau PET, cortical thickness, and cognitive impairment. So some more evidence. So plasma percent p-tau 217 is a tongue twister. Improved diagnostic accuracy in primary and specialty care. And so when biomarkers were used, or when biomarkers aren't used, clinical diagnosis is incorrect 40% of the time in primary care and 25% of the time in specialty care. When biomarkers are implemented, testing increased the diagnostic accuracy to greater than 90% in both care settings. So we all do this as clinicians as we are assessing our patients. We are looking at all the potential risk factors for certain diseases. And so it's just, or even more important than choosing the right test, you need to be able to calculate the pretest probability. So these are all things that contribute to the pretest probability for Alzheimer's disease. So we know that age is the biggest risk factor for developing Alzheimer's disease. Gender, women over the age of 80, a family history, specifically a first-degree relative. If you have genetic risk factor information, it's important to add to your pretest probability. We have cognitive scores, and I want to emphasize it's very important to look at the pattern and presentation of cognitive impairment to really increase your pretest probability for Alzheimer's disease. The severity of cognitive impairment, lifestyle, as we learned, comorbidities, and social history. And so biomarker results, again, need to be interpreted in context of patients' clinical symptoms and pretest probabilities. Blood-based biomarkers tests should not be obtained before a comprehensive clinical evaluation, and test results should always be interpreted within clinical context. Consider the pretest probability of AD pathology for each patient when interpreting BBM tests. The positive and negative predictive values depend on the likelihood of AD pathology before testing as shown in the table below. So if you have a patient who's 75 years old with a typical AD dementia syndrome, your pretest probability could be 85%, and that would mean 98% of patients have a true positive result. But if you have a 6-year-old patient with just subjective cognitive decline, your pretest probability of amyloid pathology is 20%. And so that really brings down your true positive results. So right now, blood-based biomarkers are categorized into kind of 2 categories, so triaging and confirmatory. Triaging tests are those with greater than or equal to 90% sensitivity and greater than or equal to 75% specificity, meaning that a negative test identifies individuals who are unlikely to have amyloid pathology and no further testing for AD is necessary. But a positive test identifies individuals who are at high likelihood, but they would need a second test to confirm the presence, either CSF or PET. A confirmatory test is a higher performing test with greater than or equal to 90% sensitivity and greater than or equal to specificity, and can serve as confirmatory tests. And so a negative test identifies individuals who are unlikely to have amyloid pathology, and a positive test identifies individuals who are likely to have amyloid pathology. So there are tools to facilitate use of this in clinic. And so there's the Alzheimer's disease blood test performance database and the Alzheimer's disease blood test NPV-PPV patient covariate calculator. The Alzheimer's disease blood test performance database has all of the clinically available tests for review. So you can look at their sensitivities and specificity. I can't say it, oh my gosh. And then you can use that with the NPV-PPV covariate. So it's important to engage patients before you order these tests so that they understand what biomarkers can't do. And so you need to use plain, non-technical language to explain the benefits and risks of biomarker testing. You should inform patients that blood-based biomarker testing can provide a better understanding of the cause of cognitive symptoms and long-term prognosis and determine potential eligibility for amyloid-targeting therapies. You should explain that blood-based biomarkers test performance varies and test results could be affected by comorbidities. You should encourage open dialogue with patients and care partners to promote shared decision-making. And you should establish realistic expectations. Biomarker testing does not provide a definitive diagnosis, but it does contribute to a broader clinical assessment. And you should advise the patient to wait until the disclosure appointment to access blood-based biomarker test results to reduce the risk of misinterpretation, because we all know that doesn't go well. So some tips on disclosing blood-based biomarker results to patients and their care partners. So first, you want to say, are you wanting to learn this right now? And so definitely gauge if they are ready to learn this information. Then you need to provide a simple description of the results, such as this test was positive for the proteins we see in Alzheimer's disease. Describe the certainty of the results, so hopefully you picked a highly accurate test and you have confidence in it, and then you have higher confidence that Alzheimer's disease is present. And then you want to connect the results to the clinical diagnosis. So take it back to the patient and help them understand why you ordered the test in the first place, because it's not always clear to them. You want to discuss prognosis, treatment options, and next steps, and then provide the options for referral or follow-up if you're the one to manage their care. So indications for a referral to neurologist, neuropsychologist, psychiatrist, or geriatrician. And so if the diagnosis is inconclusive, that is, or if the presentation is atypical, if there's significant behavioral or neuropsychiatric symptoms, if it's an early onset dementia, meaning under the age of 65, or if a second opinion is requested, or if there's family dispute on, if a family member has concerns about a patient, but other family members have no concerns. That often happens, and sometimes we need a second opinion to further clarify. And of course, if you think that a patient would be a good candidate for amyloid targeting therapies, you should refer as soon as possible. So here is a checklist of all the things that you should include in a referral to a specialist. And so you should always include the results of cognitive assessments, bonus points if you have serial measures. You should include all diagnostic testing that's been completed, such as a baseline brain MRI, all the routine blood tests, ruling out metabolic causes of memory impairment. And then if you have ordered an AD-specific blood-based biomarker, of course, include those results. When referring, you should also have a clear history and how you came up with the diagnosis of mild cognitive impairment, and any genetic testing if available. So we'll hear from George again.
I think blood-based biomarker testing is a wonderful evolutionary product, if you will, available to doctors and patients today. I think information is invaluable because it dispels fear. I mean, when you know something. In my case, when I had a diagnosis, I had an explanation, in a sense, for things that I thought, is this me? Is this something else? Is this really happening? When you have a diagnosis, you have an explanation. I found it very comforting, actually.
And so we have Hector again, and what has changed is that he has now brought his adult daughter with him, who completed the 88. He scored a 3, again, greater than 1 suggests cognitive impairment. He had a MoCA, which he scored a 21 out of 30, with deficits in recall, visuospatial and executive tasks, and orientation, with preservation of language and attention. His FAQ was 0 out of 30, indicating no significant functional impairment, at least that the daughter knows of. And his PHQ 9, he scored a 9, indicating mild depression. His lab work and neurologic exam were all normal, and his brain MRI revealed mild hippocampal atrophy. His clinician ordered a blood-based biomarker test, specifically the Alexis Plasma p-tau 181 test, which has a 90% sensitivity and 75% specificity, and his result is positive. All right, and so now is your chance to rethink your choice. So Hector's cognitive assessment revealed that he has MCI. His primary care clinician ordered a blood-based biomarker, the Alexis Plasma PETA 1881 test, which again has a 90% sensitivity and a 75% specificity. And his test result is positive. This test has approximately, that's repetitive. How would you interpret this result? You guys did really good. So I think I won.
Everybody did better.
Very good. So yes, it indicates that he may have amyloid pathology in his brain, but he needs further evaluation. And so some small group discussion, key insights there. So again, Hector's pretest probability was fairly high, approximately 40 to 60% of patients aged 64 years with MCI are amyloid positive. He also has additional risk factors, including his medication use, his comorbidities, his lifestyle factors that may further elevate his pretest probability. His result was positive. Again, I keep mentioning it, the 90% sensitivity and 75% specificity is a triaging test. And a positive triaging test results are not conclusive, and he is identified as someone who's at a higher likelihood of having amyloid pathology. And so therefore, Hector needs additional biomarker testing to confirm amyloid pathology and determine whether he's eligible for treatment with an amyloid targeting therapy.
Am I doing the take-home list? That's me, right? So we're getting ready to wrap things up, and we want to talk about take-home messages. So we want you to come away from this presentation with some really actionable things, some new information, I think especially the blood-based biomarker information, and then also the kind of ways to intervene. So like we've talked about, it is never too early and it's never too late to think about brain health and dementia prevention. So we want to make sure that when our patients get a diagnosis, they don't throw up their hands and say it's futile, and that when we're worried about them because they have modifiable risk factors, that it's not too early. So those modifiable risk factors, that's really our bread and butter, especially in primary care. This is our opportunity to really make a positive impact in our patient's life and really try to slow the progression and reduce their risk for dementia. So we have reliable tools. We know that we can use them. We need to figure out how to incorporate them efficiently in our practice since we're all stretched for time. So we want to be familiar with it. I encourage y'all to take these resources, look at them, figure out how can I work this in? Who in my staff do I need to have help me so I can do this and really give my patients the best care possible? So we want to use informants, we want care partners, we want family members, whoever can help give us this greater picture of how our patient acts when they're not in our office. Because again, patients can appear less able and more able sometimes in our office than they are when they're out in the community. And then we can use blood-based biomarker testing in primary care. And this is, I'm developing this in my practice, it's new for me too. But we want to facilitate the early diagnosis. We want to reduce the time because when we get a positive test, we see that we reduce those wait times. The positive test gets the attention of our neurology colleagues as well. It gets the attention of our geriatrician colleagues. Those patients are designated as higher risk who need more help faster. So this is your opportunity to ask us questions. We've got, for people online, we have the live chat. And then we also have ways through your app, through the code, that you can send us questions and complete the final poll.
Do we have any questions in
No,
yet
that's
on
what I was
the
looking
tablet?
for. Any glasses to see them though?
Oh, here we go.
something you want to see? Oh, that's the live channel there. I don't have questions yet.
Okay,
Oh, we
great.
got audience
Yes.
questions. Great.
I was just wondering if it would be more beneficial to do the MRI first or do the biomarkers first.
Probably MRI.
Okay.
Yes, definitely.
Yeah,
Actually.
the MRI is part of that tier 1. You really do want to get the MRI. Remember, you want to get some basic labs and neuroimaging on everybody, and you're going to need that information for that pretest probability information. Like in the case, we just saw it was perfect. We knew he had the hippocampal atrophy. Say, oh, that's really concerning. So now again, we've got this positive triage test. Let's get this guy in a PET scan.
So my first question, are any of you prescribing the infusion therapies?
So should we go down the line? Go ahead.
Yes. Yep.
Well, you're from a center where they've been doing all the clinical, so probably some of the most cases in the world, maybe.
Yeah, we have over 600 patients receiving
It's
therapy.
fascinating to talk to your colleagues there in terms of the experience they've had and what's, we know from the trials and what they've seen. Yes, I prescribe those, and
I have not yet, to be honest,
yeah.
in a small primary care practice, rural.
So my follow-up question to that would be, have you prescribed it to anyone who has subjective cognitive impairment? Because I'm also at an academic center. We have about a little over 100 patients who have done the infusion therapy, and working up someone right now who had a positive p-tau 181, but his MoCA was normal. It was a 27, so he's just at that subjective stage, waiting on the amyloid PET results to come back, so we don't have the confirmed amyloid pathology. But say it did come back positive. Have you had anyone in that situation where they hadn't crossed the MCI threshold and they were started on the infusions, because we know they're beneficial more so when you start them earlier on rather than waiting until later in the disease process?
I mean, that would only be in the context of clinical trials at this point, and I can't wait to see the data, and that's really interesting. Right now, the indication for these therapies is for people who have mild cognitive impairment or early mild dementia and confirmed amyloid pathology. So for people further upstream, even though, I love showing that slide about primary, secondary, tertiary prevention, hopefully we'll get to an era where we can move even further upstream, but that would not be clinically appropriate yet.
Right.
That was also what I have seen, so thank you for
We
sharing.
have another question over there. Get your steps in. Get over there. Hand up high. Come on.
Kind of going back to the modifiable risk factors, I'm curious what your opinion is or what you've seen for weight loss, like GLP-1s. I don't know what the research shows with older adults, if that's something that you would recommend or not.
So there was a recent clinical trial on GLP-1s for the treatment of Alzheimer's disease, and it was the results, the placebo line and the treatment line were on top of each other. It was kind of surprising because we were expecting to see at least some results, but when it comes to AD-related dementia, there was no benefit, but the research is ongoing.
Yeah, very exciting. I mean, there's so we talked about amyloid targeting therapy, but so many different potential mechanisms and pathways that could be, in terms of bioenergetic, metabolic, vascular, blood flow. So hopefully we'll get to an era in our lifetime where we actually can treat this as a chronic condition through a multimodal, like cocktail approach. So really exciting to keep an eye on the GLP-1s, but I would also just remember to caution you and your older adults to make sure that you're not losing muscle mass, when you're losing weight.
There is a question in the chat. Is anyone experiencing recent difficulties with the FDA-approved LumaPulse blood test due to reagent supply? And if so, what alternatives do you have? given that Lumipulse is the only FDA-approved test?
Well, there are multiple FDA-approved and multiple clinically available.
One of them.
Haven't personally encountered that yet, but wouldn't be surprised, and I know there have been issues, but.
Yeah, I've not had that issue, so I can't speak to that.
Yeah, great question though. I mean, with any of these things where they're new, we're all figuring it out clinically, and then, it's one thing to understand the guidelines, but then there's, which lab and getting it paid for. So it's a work in progress, and certainly, all care is local. So that's interesting. I hadn't heard about I knew about some recall issues, but not reagent supply issues. Huh.
What about insurance coverage? That was a question that came up. Are you having any difficulties with insurance coverage for blood-based biomarker testing?
So in our experience, blood-based biomarker testing is not covered by insurance at this time.
Depends. It really depends on what test. It very much depends. And I'm reticent to even answer like now because it's all changing so quickly. And there is some coverage for I actually have seen successful coverage of particularly of the FDA approved tests. It just, you have to really work with your lab and make sure that you're using the right diagnostic codes, right CPT codes, et cetera. And then amyloid PET scans, really remarkably, very readily covered. And again, remember neuropsych testing, we didn't talk about much this afternoon, evening, but for your Medicare patients, you should be able to get them neuropsych testing. That can be really helpful too. Do we need the mic? Because I think we have people online too. Well, I'll repeat your question then.
I was going to say, I'm really loud. I probably don't need that. So with the triaging test versus the definitive test, if cost is a factor, how do you go about approaching that when patients might not be able to then afford that second set of biomarker testing?
So questions about cost consideration and in terms of which testing you might do.
And just how, if they do have the test that's, there we go, the positive triage test, is that enough to go off of if they then can't afford to do another set of testing if it isn't covered? Like the example for Hector, we said that was a positive triage referral for more biomarker testing. For some patients, that might not be a financial option.
Well, the next test for him is going to be an amyloid PET scan or a CSF analysis, though I don't know who would choose that at this point between those two, and that's readily going to be covered. So I think it's really important. This is amazing that you're asking these great questions about the cost so that you can make sure your patients are informed. So much of this, whether it's the cost, whether it's the potential risks versus the potential benefits, shared decision making is like front and center in all of this. There's very little that's a clearly one right answer, one wrong answer. It's a lot of gray area. So this is really good that you're asking these questions so that you can know in your setting, with your lab, with your practice, what kind of experience are we having? Are patients getting stuck with the bill or not? If so, how much? And then, that can go in. But before even all of that, you want to make sure that you have a good systematic approach to your care, and that's why this care toolkit is so good, so you don't skip a step in terms of the assessment, in terms of the evaluation, in terms of referral, and to understand in the best case scenario how all of these different tests could best be deployed and best help you in your care. And then adding on this layer is critical. So really great questions.
Thanks, everybody. We're going to kind of wrap things up here. So again, if you haven't had a chance to scan those QR codes, and we'll be up here for questions afterwards as well. But we really want to thank you. We want to thank you for joining us, spending your evening with us. please scan that QR code. You can visit peerview.com to get credit, so you'll get your credit for the activity, and then there'll be some online activity based on this event as well. So if you want more information, you can email Peerview, and then yeah, feel free. I think we're all able to hang out a little bit if you have further questions.
All right.
Okay, everyone, please check your devices.